Today we're going to do something a little different. We're going to put you right in the middle of a clinical case, almost like a medical simulation. You'll get the clues piece by piece, and your job is to solve the mystery. Ready? Let's get started.
Okay, picture this. You're in the ER. It's busy. A 28-year-old man comes in and he is clearly in a lot of pain. Our job begins right now, and the first step is always the same. We need to listen.
So let's dive into the presentation. This is where we gather all the initial information. What is the patient actually feeling? What's his story? The first clues are always hiding in here.
Now listen to these details because they are so important. This is way beyond a simple stomach flu. He's got severe crampy pain. The diarrhea is happening 10 to 12 times a day, and he's seeing blood and mucus. That's a huge red flag. He also describes this feeling called tenesmus, which is this awful, constant urge to go to the bathroom. But here's the kicker. Even when he does, the pain doesn't go away.
And just when you think you have a handle on it, the plot thickens. This isn't brand new. He tells you he's had milder episodes like this for the past 8 months. This points us away from an acute infection, like food poisoning, and points us towards something chronic, something that's been simmering for a while. And notice, no recent travel, no sick friends or family. An infection is looking less and less likely.
All right, we have the patient's story. Now it's time to get some objective data. We're moving on to our own investigation, the physical exam and the lab work. What can we see, measure, and prove?
So on exam, the guy is obviously miserable. He's got a low-grade fever, his heart's beating a little too fast, and he's sweating. His belly's a bit swollen, and when you listen with a stethoscope, the bowel sounds are hypoactive. They're quiet, sluggish. That's a sign that his intestines are seriously inflamed. The pain isn't in one specific spot either. It's all over.
And now the lab results start rolling in. First up, his white blood cell count. Normal is usually under 11,000. His is 15,800. Boom! That's our first piece of hard evidence. His body is in a full-on fight against some major inflammation.
Next, his hemoglobin. This tells us how many red blood cells he has. For a young guy, it should be well over 13. His is down at 10.3. He's anemic. And this lines up perfectly with his story of seeing blood in his stool. It's proof that he's been losing blood for a while now.
And then we see this number, his platelet count. Normal is usually under 450,000. His is a jaw-dropping 754,000. This is what we call a reactive thrombocytosis. It's the body's panic button. The inflammation is so severe that his system is just pumping out platelets in response.
Okay, time to look inside. The abdominal X-ray is pretty telling. You can see right here that his colon is dilated. It's swollen up with air. This tells us two critical things. One, the problem is definitely in the large intestine, and two, the inflammation is bad enough to make it swell. Thankfully, there are no signs of a perforation, which is a tear. That would be a surgical emergency, so that's good news.
So, let's recap. We've got a young man with a chronic history of bloody diarrhea who is now in the middle of a major flare-up. His labs are screaming inflammation, and the X-ray points the finger directly at his colon. All the pieces are on the table. It's time to solve this case.
So, what do you think? With everything you've just seen, the chronic nature, the bloody diarrhea, the anemia, those wild inflammatory markers, and that swollen colon, what's the single diagnosis that ties it all together?
If you landed on ulcerative colitis, you are absolutely correct. This is a textbook presentation for a moderate to severe flare of this specific type of inflammatory bowel disease.
So what in the world is ulcerative colitis? Well, in short, it's an autoimmune disease. The body's immune system gets confused. Instead of fighting off germs, it launches an all-out attack on the healthy inner lining of the colon and rectum. It's basically friendly fire, and this constant assault creates inflammation and ulcers, which causes all the symptoms we just saw.
But hold on, we're not quite done. In medicine, you can never be 100% sure about ulcerative colitis without considering its sibling, Crohn's disease. They're both types of inflammatory bowel disease, IBD, but telling them apart is absolutely crucial because they're treated differently and have very different long-term outcomes.
So what's the number one difference? It really boils down to geography. In ulcerative colitis, the inflammation starts down in the rectum and spreads up the colon in one continuous, unbroken patch. But with Crohn's disease, it's totally different. It can pop up anywhere from the mouth to the anus, and it does so in random patches with healthy tissue in between, what we call skip lesions.
Let's break this down a little more. You can see here, UC almost always starts in the rectum. Crohn's often starts a bit higher up. We talked about the pattern. Continuous for UC, patchy for Crohn's. Now this next one is huge. UC only affects the very inner lining of the colon, but Crohn's can burrow through the entire thickness of the intestinal wall. This is why Crohn's leads to things like fistulas and abscesses. And check this out. For our patient, that really prominent bloody diarrhea is classic for UC. Finally, and this is key, surgery to remove the colon can actually cure UC. For Crohn's, surgery is just for managing complications because the disease can always come back somewhere else.
Okay, we've got the diagnosis. But that's just the beginning. For our patient lying in that hospital bed, the most important thing is what we do now. We have to get this flare under control, and then think about the long road ahead.
So, the immediate game plan is simple and direct. 1. He's admitted to the hospital, no question. We need to watch him closely. 2. We get stool samples. We're pretty sure it's not an infection, but we have to prove it. And 3. We start treatment right away with high-powered anti-inflammatories, corticosteroids, to tell his immune system to stand down.
And for the long haul, the goal is simple. Get him into remission and keep him there. This means a lifetime of medications that can range from milder drugs to very powerful immune-suppressing therapies. We also have to be constantly vigilant for scary complications like toxic megacolon. That's when the colon gets so inflamed and dilated that it just stops working and can even burst. And maybe the most important long-term point, all this chronic inflammation dramatically increases his risk of colon cancer, which means he'll need regular screening colonoscopies for life.
And that brings us to our final thought. We've gone through all the data, the labs, the x-rays. But now, think about the person. This is a 28-year-old man just starting his career. A chronic, incurable diagnosis changes everything. This is the beginning of a lifelong journey for him. And it's just a powerful reminder that behind every single clinical case, there's a human story.